Welcome back to the Menopause and Cancer podcast, and a warm welcome to our HRT After Breast Cancer series. This is episode 4. If you haven't yet listened to episode 1, 2, and 3 or watched it back, please do so. In episode 1, we talk about all of the studies that we have up to date for using HRT after breast cancer. In episode 2, we speak to an oncologist that explains to us what does it mean, what is this risk we're talking about, who holds the risk, is it the patient, is it the doctor, and how do we move forward. In episode 3, we spoke to a doctor and breast cancer survivor who prescribes and uses hormone replacement therapy. And on today's episode, I want to take us even further in this thought process and speak to another prescribing doctor. Dr. Louise Newson is a member of the Royal College of Physicians. She's a fellow of the Royal College of GPs. She's a menopause specialist, and she's a member of the UK government's menopause Taskforce as well. I want to understand from Dr. Louise Newson what it was like when she was prescribing HRT to a breast cancer survivor for the first time, what her thought processes were, what guidance she looked at, and how she makes these difficult decisions with her patients. We all agree, every expert I have spoken to agrees that more research is needed to provide evidence-based guidelines for the use of HRT in breast cancer survivors. We've also heard from Professor Richard Simcock on our episode number 2 that we're most likely not going to get really good randomized control trials, certainly not in mine and your generation. So what do we do? How do we empower women to make informed decisions about their health? I know, because I speak to so many of you, that many of you are thinking about their long-term health. You're really worried about your bones, your heart, your brain health. You might have been put into menopause very early at a young age, and maybe you were told hormone replacement therapy isn't for you, but you still want to know, what would your risks be of going on HRT, and what are your risks of not going on to HRT? And so we need to look at us as a whole person, don't we? And I have no idea what your worries and concerns and thought processes are. And they might be very different to my worries, thoughts, and thought processes. And so it's really important that at the end of each of those conversations I'm providing you with, you step back and think, what was relevant for me out of this conversation? What do I want to explore now? And where do I go for it with it? And so I'm delighted to welcome Dr. Louise Newson onto the conversation, to have this conversation with us. And it's just brilliant that we're all here talking about it. Oh, Louise, it's amazing to sit here with you. Thank you for your time. It's a real honor.
Oh, thank you for inviting me. I love watching what you're doing. I've known you for a while, but it's just so needed and it's brilliant. So well done to you.
Yeah, thank you so much. And of course, we're going to talk about HRT after cancers, and especially estrogen positive breast cancer, some ovarian cancers in a moment. But one thing I want to throw out there is when you talk about hormone replacement therapy, and I'm just saying this because it resonates probably with a lot of the audience, for those who are told they can't have it, it's like alarm bells. And of course, right, so there's a lot of people, and we're talking millions of people who are told by their oncology team that hormone replacement therapy isn't an option. So I guess the louder the voice for how beneficial hormone replacement is, the more maybe isolating and devastating it can feel for those who are told they can't or shouldn't go on hormone replacement therapy. And the first time you as a doctor, when you were confronted with that person that came to you as a doctor, as a GP, can you explain to me, can you remember that first person?
Yeah, I can very well, actually. And a lady, so I think there are two things here. I think the first thing is, in any walks of life, you can never say never. You've got teenage children. I've still got 2 teenage children. And I'd like to say to them, you must never get really drunk at a party that you don't remember what you've done the next day. But they've still done it. Not all of them. My 13-year-old hasn't yet, but I'm sure there'll be times. But in medicine, I don't think I'm there as a patient's advocate. I'm not there as a dictatorial person to say you can and can't. And the most important thing in my work is about empowering people in shared decision making, sharing uncertainty, sharing risks, sharing benefits, and also looking at informed consent. So those are the most important things. I also talk about how wonderful it is to do a headstand most mornings. Now, most people can't do headstands, and you could tell me off for shouting out about that. But actually, there's a lot of people that tell me they're learning and they're trying to practice and they feel really good about it. So, if they really take umbrage, they don't have to follow me. I'm not going to their houses and knocking and making them do things. So I do feel there is a bit on social media that gives people entitlement to be incredibly rude. But talking about my first patient, so I set up a clinic on my own 8.5 years ago, because I wanted to help some of my friends, some of the mums from school who were telling me they were on antidepressants. And then after a few weeks, I literally was seeing 1 or 2 women a week then. There were women that were traveling for miles. We didn't do online consultations because no one really knew that there were things we could communicate. It was all pre-COVID, of course. So I saw a lady once who was 38. She'd come down from Scotland. She'd got a train. She'd stayed overnight. She'd got a bus. She arrived and she was telling me how awful her symptoms were. And actually, this is one of my first patients. So she hadn't had cancer, but she had BRCA, and she'd been advised to have her ovaries taken out. But her life had fallen apart, so she couldn't work anymore because she had such bad memory problems, fatigue. She was very anxious. She was very low in her mood. She had awful muscle and joint pains, limiting her exercise. And she had no libido at all, recurrent urinary tract infections, and her partner had left her as well. And I said, gosh, I'm really sorry to hear how you're struggling. How long has this been going on for? She said, 3 years. And I said, oh, you're 38 now, so what happened 3 years ago? She said, I had my ovaries taken out. And I said, oh, did anyone offer you or talk to you about hormones? She said, no, they just said, see how you get on. And I said, oh. So then I gave her like HRT, as in the same as I would have done as an NHS GP. 3 months later, she comes back and she said, I cannot believe that I've been suffering for so long. And so these are people that I'd never seen in general practice, because I wouldn't allow people to be denied a treatment that would be beneficial for them. And seeing more and more people obviously made me want to write more, give more information out to people. And then after about 6 months, a lady came into my clinic, really lovely lady. I still see her annually. She came in and she said, I've had a hysterectomy. I'm having all these sweats. I'm feeling dreadful. I've reduced my days. I've actually had 3 divorces now. I have to have a bag of clothes because I'm sweating so much and I'm changing them all the time. My quality of life is, and I thought, well, she's quite straightforward. She's had a hysterectomy. I can start HRT. I said, anything else in your history? No, I haven't had any blood pressure. I've had nothing else. Oh, yes, I had breast cancer a few years ago. And I was like, oh, no. So she said, yeah. I said, well, do you remember what it was? Was it estrogen receptor positive or negative? What treatment you had? Anyway, she had an estrogen receptor negative breast cancer a few years ago. She'd been under the oncologist, but she wasn't on any other treatment. And I sat there and thought, oh no, what do I do? So I went through all the options. I went through all the alternatives. I've tried that. I've tried this antidepressant, that antidepressant. Everything's given me side effects. And she was on some vaginal hormones because of her recurrent urinary tract infections. And I just looked at her and I thought, I just don't know what to do here. She's come for me for specialist advice. I'm on the clinic on my own. I can't ask anyone else. And I said, well, we have got estrogen, and studies have shown it lowers risk of breast cancer in women who've never had breast cancer. For women who've had breast cancer, there isn't any definite data. She said, but I need to get to work. I can't earn any money. I'm divorced. I spent all my money on my divorces. I want to enjoy my life. And I'm like, well, I can give you this gel and you can try a really low dose, and I'd never given it to anyone with history of breast cancer before. And I said, but I think I'll review you in 3 months and then we can see if it's helping. So she went off and she was really happy. And I was absolutely petrified. I couldn't sleep. I thought, what have I done? This is awful. Like, what happens? It was really quite hard. And then she came back 3 months later and she said, I'd just like to thank you, Dr. Newson. You have transformed my life. And I said, oh, but I was going to talk to you about maybe weaning off because I feel a bit nervous. And she said, no. She said, I know there might be a risk, but actually I've extended my hours at work. I've got a new boyfriend. We've just been on holiday together. She said, I can grow my hair because it was so short, because she was so sweaty. She said, I can exercise now. I couldn't exercise because of my joint pains. I've lost some weight. I'm just feeling incredible and I just want to thank you. And I said, but I've been quite worried. She said, well, I haven't, because I made the decision. It's my body, it's my life. I can decide what I want to do. And I just thought, actually, you've given me so much confidence. And she came and spoke in one of our conferences, actually, with our clinicians recently. And we were both recounting our views of the consultation. She said she sensed that I was really nervous, but she felt it was the right thing to do. She thought very carefully what she was doing. And she liked my openness, because in general practice, I've learned a lot. You share uncertainty with patients, you know. And she knows that she can stop her gel at any time. She's completely in control. And that was now 8 years ago. And she's just so happy and so well. And her not just her quality of life, but the way she exercises, the way her diet is, it's enabled her to do things that she was just hitting a brick wall. Now, she's an individual. I'm not saying that everyone who's had an estrogen receptor negative breast cancer should have HRT, but for her, it was the right decision. And so in medicine, you learn through your patients as well as from the evidence. And so over the years, you know, we see a self-selected group of women who come to us because they can't be listened to elsewhere. They have nowhere else to go. And a lady said to me recently, she'd had cancer before, and she said to me, Louise, there are treatments available for cancer, but there's no treatment available for dementia and osteoporosis of the spine. And it's my body, it's my life. And I thought, oh gosh, yeah, you're absolutely right. And so, and this is where I think, Danny, the perception of who I am and what I do is really, it's a shame, because it is, like, I don't live with these people every day, and I don't know what it's like to have an illness. I don't like that they've gone through. I don't know what the symptoms are like. I don't know what the suffering is like, and I don't know how they're even going to benefit or not from hormones. And there's so much uncertainty. And there's lots of people say, well, we haven't got the randomized control studies. No, but we'll never have them. So what do we do in the meantime? And I was at a conference recently. I won't tell you where or who did it, but someone said, this was a menopause specialist, and she said, of course, women who've had breast cancer at any time can never have HRT. And one of the doctors put their hand up and said, yeah, but I've seen quite a few women who are really struggling mentally with their mental health, really struggling, and we don't know what else to do with them because we've tried everything else. What would you suggest then? And she said, well, one of the things that sometimes helps is maybe doing some knitting or taking up a new hobby. And I thought she was joking. And they said, but we can't even give testosterone, because you can't give testosterone unless you can have HRT first. So therefore, there's no hormones at all. End of conversation. And this GP looked a bit like, well, what do I do with these women then? And I thought, well, I'm not going to say anything, because everything I say in these sorts of meetings is very inflammatory. But I felt really sad, because it's like treating people like numbers. And everyone has, you know, most women can make choices. And that's all what it's about, I think.
But when you were that young doctor, I want to go back to that moment when you were unsure about that first patient with her history of cancer or breast cancer coming in. What did the guidance say? Did the guidance change since then? So what is the guidance actually telling you as a doctor what you're able to do in terms of hormones or not?
Yeah, so we've got good guidance. There's obviously the nice menopause guidance, and there's the nice breast cancer case guidance, and they do say in exceptional circumstances women can be considered for HRT following breast cancer. So, and also we have to remember, guidance is what it says. It guides, it helps. It's not a regulatory document that you have to work out of. And I've also said we've got shared decision-making guidance as well, which is really important for all walks of medicine, because it says, you know, doctors and patients are allowed to have different opinions, but it's the patient has to be involved. And so, so the guidance is clear that we can give it to some people. So I'm not doing anything that contradicts any of the guidelines at all.
Yeah. And of course, we all have different worries. And when I speak to hundreds of people about this, the first question I now really ask is, what is your biggest worry or concern? Because is it that you're worried that your cancer will come back because of a treatment or because of something you do? Like, is it, I was worried sugar might make my cancer come back, or if I don't exercise, or is it maybe the HRT that you might prescribe? Or are you worried that you're going to die from that cancer? So that's a
Yes.
different worry.
It's
Recurrence is a
totally
different worry.
important. Yeah,
So
and
it's important to talk about that, isn't it?
it's really crucial. So I saw a paramedic a few years ago. She's really clever. She's done a lot of research. She's got a PhD as well. Really clever. She had a breast cancer, and she was on an aromatase inhibitor, finding it quite difficult to cope with the side effects. And she just came for some advice. Lots of people just come for advice. And she came, she'd read so much. She'd read so much about other drugs and treatments and diets and all sorts of things. And she tried a lot herself. Her oncologist was really involved. She was great. And she said, Louise, or Dr. Newson, she said, I've come to a crossroads. She said, in my mind, I've got two choices. I can carry on as I am, but I absolutely can't work. And what I could do is go and live with my mother who lives in Scotland, and I can just exist for however long I've got in my life. And that might be fine. Or I could consider maybe just taking some testosterone with my aromatase inhibitor, knowing that it might shorten my life, knowing it might increase my risk of recurrence. But actually, then I can carry on with my studies, I can carry on with my work. And that's for me to decide. And I think she really painted such a great picture for me as to, yes, it is about making choices, you know. We all make choices in life, but I think when the choice is taken away from you and you're told you absolutely can't, and you're struggling, if you're not struggling, it's fine. Well, not fine, but you know what I mean. I think that's the problem when people just say, it's all about my breast cancer and nothing else, and no one considers. But there are other women who use, like you quite rightly say, Danny, who every day are going to worry about recurrence. And I always think to say those people, the last thing I want to do is for them to take something or do something that they're going to regret. So, like you're saying about sugar or whatever, if they, you know, if they know that there might be an increased risk of recurrence and they've done a lifestyle or taken something and then they get a recurrence, if they're going to blame themselves for it every day, then absolutely they should mitigate all risk as much as possible. And
Yeah.
that's where being an individual is so important.
Yeah. And you spoke about something that is really important about people not being heard when they ask the question. So we hear that a lot of the time, that people want to try and ask. They might see a menopause specialist, or they might just ask their oncologist, and they just say, and what about me? What are my options? What HRT, after my particular type of breast cancer, for example? And they just push back. They're not being given that conversation. And what we then hear as an organization is a lot of different stories, and it's a bit mad what's happening out there. So we have people who are on testosterone gel after estrogen positive breast cancer. We know people that are on the implants. They have testosterone implants when they are on aromatase inhibitors, all here in the UK. We, of course, know people that are on normal hormone replacement therapy, but some take tamoxifen and some don't. So there are so many different layers. It's not just one thing, right? It's not just HRT after cancer
No.
where it may be contraindicated. It's you, this person with your wishes and desires, with your very individual history of cancer. And I'm going to just read something to you that just popped into my inbox today. Isn't it funny how sometimes you get the right emails on the right day, knowing I'm going to speak to you? This person said she proceeded to have a formal appointment with a menopause specialist after an estrogen positive breast cancer a few years back. She is now, after having gone through pros and cons of HRT, I'm now having a small dose of transdermal estrogen and oral progesterone. I'm now, for the first time, fully compliant with tamoxifen as a result. I hadn't been at all compliant due to side effects up until now. I feel my life is transformed, and I'm running the London Marathon on Sunday, which is
Wow.
quite emotional. She's saying herself, I think I'd be so emotional on Sunday, I could possibly become dehydrated through fluid loss in tears, which is absolutely lovely. This person is an oncologist herself, actually. And so what I know is really difficult decisions. These aren't easy decisions. This is often years of thinking, of planning, of feeling a certain way, of being worried, of trying to find the right doctor to work with you, talk me through some different cases. Is there a difference if someone is on tamoxifen, like in that
Oh, totally.
case?
I think the most important thing is that everyone is different. And if anyone who's listening has had breast cancer, it's not just a one disease. It's very different in different people. So, and that's really crucially important. And the other thing is that there are always choices, and it's not just like one treatment or not. There are always options, and I do that a lot in anything in medicine. And also, I often say to patients, if this doesn't work, we've got this option, because I think when you know that there are choices, it's really important. And a lot of people seek us out because they want to hear all the available choices, and they say, well, I might not want something now, but at least I know it's an option if something gets worse or if this happens or whatever. So yes, absolutely. So a lot of it will depend on the type of cancer they had, how long ago it was, and also what matters to them most, what symptoms are worst, or or if there's a disease that they're worried about more. If, you know, I've got some people who've got this very strong family history of osteoporosis, and that what they worry more about that than a breast cancer recurrence, for example. So that the concerns is really, really important. Their expectations of treatment. You know, if someone thinks they're going to take HRT and be able to swing from the chandeliers and lose 28 stone and feel incredible, like HRT is not going to do that for them. So they've got to be thinking, you know, what are their reasons? What are they thinking? But then the other thing is thinking about their adjuvant treatment that they're on as well, if they're on an adjuvant treatment, because we all know that there are different side effects. And some people don't have any side effects and some do. And so I've done a great podcast with Tony Branson. I've done two with him actually, but he talks in the first one about, you know, having a drug holiday. So rather than just putting someone on hormones, actually, you know, I've seen people that have been on an aromatase inhibitor for, you know, 4 years, 10 months, and they've got the final 2 years that they want to take, and they're absolutely on their knees. Well, one lady that happened, all she did was just stop it 2 months earlier and had some vaginal hormones for her urinary tract infections. And that transformed her life, just to have the permission that she, like the 5 years was, you know. And then tamoxifen, I think, is very interesting because, as I'm sure you know, Danny, it can increase estradiol levels as well, by sort of 3 to 10 times in people. And sometimes I've done baseline estradiol levels and they have been raised in people on tamoxifen, and the studies show that as well. So like this lady who you described, a very low dose of estradiol, when you're on something that might increase your estradiol level, is not as scary as people think. And so when we say HRT, are we meaning estrogen? Are we meaning progesterone? Or are we meaning testosterone? And that is really confusing, because I was talking to a professor of oncology a few weeks ago, and I just said to him, look, you know the pathway where all our hormones come from cholesterol, and then they go to progesterone, and then they go to testosterone, and then it's aromatase to estradiol. When you give women aromatase inhibitors, you're stopping the conversion of testosterone to estradiol. And he was like, yeah, of course. I said, well, yes. So hear me out a minute then. If you're stopping you're inhibiting that enzyme aromatase, you're inhibiting production of estradiol. Therefore, you're not worried about testosterone then, are you? He's like, no, I would. I said, okay, that makes me feel better, because often and increasingly I do it if someone wants to be on systemic hormones and I think that might benefit, then I'll start testosterone on its own first and then consider if they even need estradiol or not. And I think and there's quite a few people I know in America do that too. And I think that's just a very interesting way. So is testosterone HRT or not? It depends on how you define HRT, of course. But I think knowing that there are choices and not everyone's the same. And then we have to really mention vaginal hormones, which are not HRT, they're not systemic. And so a lot of
Yeah.
people are still told they can't have vaginal hormones, which is very different and usually are very safe and very effective for a lot of women.
I, I want to talk about that. Let's talk about that in a minute, and remind me to get to it. One thing that is so counter intuitive is, you know, when you just spoke about the role of estrogen, for example, is when a person after an estrogen positive cancer is told, we're going to do everything to block that estrogen, either from your breast tissue or from your body with aromatase inhibitors, and it's really going to help you reduce your risks of a cancer recurrence. Of course, you're thinking of, I'm not going to give hormones back to that person if we're going to try and do everything to sort of reduce or strip that body. And it's very, it makes sense, doesn't it? But what happens to when this patient then maybe survives 10 or 15 or 20 years? Because often what we see is people don't come and say, I want to know my options in terms of managing menopause after cancer when they're going through it. Of course, we see a lot of patients when they're going through chemotherapy and they might be really sort of knowing what they're up against and they want to be prepared. So they come into our community and organization. But a lot of the times it's many years after, 12 years after a successfully treated cancer. You know, many people are very young. They might have had a bowel cancer diagnosis. On average, we have worked out it takes people 2.5 years to get their hormones back, even if they're not contraindicated. It is, 2.5 years too long, really. But what do we do with all of those patients that are successfully treated, perhaps for breast cancer or any other cancer, and they then go through menopause naturally? Again, they're getting a big pushback on all sides. Doctors, GPs don't know what to do with them. And then the landscape out there is a bit confusing because what we hear, it depends very much to what clinician they see, is to what treatment they might be offered or not offered. And that's not fair either, isn't it?
No, I totally agree. And I think in medicine, when you have lots of conflicting opinions, then it means we don't know the evidence. It's
Yeah.
some things are very black and white and some things aren't. And, sometimes if you ask 11 people an opinion, you'll get 28 different answers because we've all been trained differently, we've had different clinical experiences, we see different demographic of patients as well. And so you can't generalize. It's really important. And you can't in anything in medicine. I actually think, medicine is a science and an art. The art is individualizing care. And sometimes we forget that we are allowed to do that in medicine. So I think it's interesting when you talk about estrogen blocking. I'm still, and I don't forget, I've got a pathology degree. So I'm very into molecular biology and basic science more than most doctors. But when I try and really quiz oncologists, like the molecular biology, how blocking estrogen really has a beneficial effect, I'm still not really clear in my mind. And is it that estrone is being blocked rather than estradiol? And I think this is really, really crucially important to try and know. But the other thing is obviously looking, I'm sure you and many people are aware of the PREDICT score, the NHS. You could just Google NHS PREDICT. And looking at what are the benefits to like similar women. We can never say individually, but that's quite useful to see how much benefit you're going to get from each individual treatment. And then it's easier to put things into perspective as well. Someone recently was being told she had to take tamoxifen and she didn't really want to. And she said, but I've seen, then they've actually told me that only 3% of people would benefit. So that means out of 100, 97 would never get any benefit for taking this treatment for 5 years. And I've decided I'm happy to take that risk because I'm otherwise fit and well. And that's her decision. Whereas other people go, 3% is a lot. I'm going to take it because I don't want it to go down to 0. And that's absolutely fine. I think what's hard is when people have had cancer at a younger age and they've had treatment, they've got through everything, and then their periods come back. And I've got a patient just now actually who's she had breast cancer when she was 22, estrogen receptor negative, and her mother reached out to me actually because she's so worried about her daughter who becomes very low and dark just before her periods. So her periods came back for 15 years and she's getting worsening PMS, PMDD, and really become almost housebound for those 3 or 4 days before her periods. But she's got BRCA genes, so she's been advised to have her ovaries removed because of the risk of ovarian cancer, as you know. So she's having them removed in the next couple of weeks. And the oncologist has said, no, you can't have any HRT because you've had breast cancer before. And so I spoke to the patient and said, well, you've had your own periods for the last 15 years. And what have the oncologist said? She said, oh, well, when I was younger, they said, oh, you'll feel a lot better when your periods come back after your chemotherapy. So, and she's now still in her 40s. So all I'm doing by offering her hormones is providing her what she was having already. But she's seen her GP who said, absolutely not. But then her GP said, I don't really know enough about it. So she's sort of stuck in limbo, really. And I think that's really hard. But actually, for me as a doctor, it's almost easier because all I'm doing is giving her back what she had. I'm not giving her any other chemical or anything else. But I think when people understand that the hormones are biochemically exactly the same as the hormones we've produced ourselves, they're really low doses. And the other thing to remember, Danny, is that they're completely reversible. So, if someone stopped using their gel today, it would be out of their system tomorrow. So they can decide, and sometimes patients do. I did a podcast with a great lady, Trudy, who's one of my patients, who decided to try coming off her HRT and didn't tell her husband. And then her husband kept saying, something's happened to you. You're really withdrawn. You're not yourself. And, but she then knew that HRT was beneficial for her. And that's fine as well. I think people sometimes think once you've made the decision, you have to either continue to not have treatment, or once you've started treatment, you have to take it forever. And I think that, again, is really important, that people know that you can change your mind at any time.
I mean, I don't know if there are many other topics in sort of medicine around women's health that are more controversial, perhaps, than the use of hormone replacement therapy after someone with a history of a hormone positive cancer. I don't know. Are there? To me, it always feels very emotive. I have a feeling in my tummy when I speak about it. I'm nervous in a way to talk about it. I want to really get it right for the person listening.
I think what's great, and I was talking to Corinne Mann earlier, actually, who, as you know, is wonderful, and some
Yeah.
doctors I know in Australia, because we there's this. What's really sad is there's very little evidence, as we know. So we're scrapping around on some really bad studies, or not well designed studies with small numbers, making sweeping statements, which is wrong. Women have been denied a treatment that will have benefits, because whether you've had breast cancer or not, you've still got a heart and you've still got bones. So you've still got risks of heart disease and osteoporosis and dementia and other conditions. So it's what's sad is there's no active research, because people just keep saying, oh, no one will fund it, nothing will be done, da, 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 da. But actually, we have a database of our patients, we follow them up, we can see what's happening. And so we're going to get a global database, which will be great. But actually, I feel things have really changed, even since that time 8 years ago when I saw that first patient. Is that what has changed? I don't think clinicians have changed. They're still nervous and worried. But what has changed is women. And women are saying, it's up to me. It's not the oncologist. And actually, we've just done a questionnaire. We're just writing up to be published for women who've had breast cancer, their experience. And I know you kindly shared the questions. And some of the stories that women have been told by clinicians, I am truly shocked. Like, I will be struck off if I prescribe you HRT. Like, no one's going to strike them off the GMC register if they've got a well-documented clinical consultation where the woman has been involved in the treatment decision-making process. And, I think women are understanding more. But they're still caught in with a bit of a fight between different clinicians. But I think the other thing is that, women are allowed to ask a second opinion. They can get all the information, and it's an important decision. I often think, what would I do if I had breast cancer? I don't know, of course, because I'm not in that situation. But actually, how you feel immediately post-cancer to 5 years after, or 10 years after, or, I've seen people 25 years later after breast cancer. And, you change, your priorities change, what you want out of your life changes, and what you want out of your future health changes as well. So I think this sort of patriarchal, you must do what the doctor told you 25 years ago, has changed, and that's good. And so I think, like, it's drawing people in, and sharing uncertainty is really important. Like, no one tells me if I buy a new car that it's dangerous because it said a randomized control study that at 32 miles an hour on a motorway you might crash or whatever. I think to be so controlled by uncertainty in one area of medicine just feels wrong.
I also wonder whether somehow someone needs to help doctors be more confident in helping these women, because I'm sure a lot of doctors are maybe worried and hesitant,
Well, I
and they
think
may
they
worry
are.
about their
No,
reputation.
you're absolutely right. They're also worried they're going to be sued. And I have this thing, I've always done it since I qualified, is that I always think, what's the worst case scenario, for a clinical decision I've made? And, when you're a GP and you see a lot of people over a short space of time, it's very, very fast. And the last thing I'd want to do is miss a diagnosis or miss something that I should have sent someone to
Yes.
hospital or referred them for, or something else. So I've always done a lot of safety netting. If this happens, you can then have this, or come back and tell me, or whatever. But I remember once, actually, there was a great doctor who's now retired, and she had breast cancer herself. And she came and lectured when the clinic had only opened about five and a half years ago. She came, and she's in Wales. And she came and she gives this great lecture looking at all the evidence, what the guidelines say, and everything else. And she ends her presentation with a picture of her horse riding up some mountain range, like without a helmet on, I hate to add. It was just awful. And she said, my oncologist should be more scared that I'm doing this than I'm taking HRT. And she said, actually, also for her, who had prescribed HRT to women who wanted it for 20 years, women who'd had breast cancer, she said, never once have I been sued, never once have I had a complaint. And actually, these patients are the most grateful patients that I've ever encompassed as a gynecologist. So she's been a great mentor over the years, actually, about enabling patients to choose. And I think that's where it's really important. And that's why what you were saying at the beginning, these messages or perceptions of who I am, I'm not going to spray everyone with HRT and force them, go around to their house and force them to have it. But I do see a skewed population of people who are really, really struggling, and just the doors almost been slammed in their faces. And I don't think we should do that. You wouldn't do that with men with prostate cancer. There's now quite a move, actually, for men who've had prostate cancer to have testosterone. And I've just recorded a podcast that should be going out soon with Steve Payne, a urologist, about it. But with men, it's an easier conversation. And actually, some of the hormone blocker drugs that they give for prostate cancer, they've reduced to 2 years rather than 5 because of the side effects. Whereas some of my patients I'm hearing are on aromatase inhibitors for 10 years rather than 5 years. So it's like, there's just this gender inequality as well, which makes me, as a woman, a bit cross.
Yeah. And now talk to me about vaginal estrogen.
Yes.
Should we all make sure every cancer patient is sent away with some information at least?
I think,
right?
Absolutely. So not just vaginal estrogen. I think I use a lot in the clinic, and personally, actually, but is progesterone, which is DHEA, which converts to estrogen and testosterone. And many women might realize that you have estrogen and testosterone receptors everywhere, but it's certainly on our perineum, our vulva, vagina, urethra, pelvic floor, trigone of our bladder. There's lots of these, both estrogen and testosterone receptors. And there's increasing evidence, the safety of both vaginal hormones, as in estrogen, but also for progesterone, which converts to the testosterone locally as well. And so some people say if they don't respond to non-hormonal treatments, then consider giving them hormonal treatments locally. But I again think you might be setting people up to fail, because certainly in my experience speaking to women who've had certainly aromatase inhibitors, the GSM, the genitourinary syndrome of the menopause, those symptoms can be horrific for women. So I think they need to have treatment, because the sooner they can start treatment, the better. So not saying, oh, have 6 months of a non-hormonal treatment and, have an antibiotic every time you've had sex, or try and avoid sex, or whatever. They should know there's effective treatment that's good for them. I did a podcast a while ago with a urologist, Steve Payne, who only realized that his wife was struggling when he actually had a chat with my husband when he was away doing some charity operating. And she'd had urosepsis quite a few times, and he's a urologist, and he said sometimes when she was rigoring, it was like sleeping next to the tumble dryer, that vibration shaking. And Paul said to him, Steve, that's going to be her hormones. Why doesn't she just have some vaginal hormones? And he went, oh, but she's had breast cancer. He said, yeah, but vaginal hormones, Steve, that will help her urinary tract infections. He was like, I didn't even think about that. He was really, but it's,
Mm.
so having that
But
information is really important.
But let's talk about the vaginal estrogen for people who are on aromatase inhibitors, who
Yes,
have a lot of the really bad symptoms. Because
yes.
a recent publication in the JAMA network at November 2023, and I'm going to link it into the show notes, um, witnessed that over 50,000 breast cancer patients and who are also were on aromatase inhibitors, that there was no increased risk of recurrence or mortality. However, the guidance still doesn't say everyone who is an aromatase inhibitor should consider and can have vaginal estrogen, right? It's still a bit flaky. There are many people who say you shouldn't if you're on an aromatase
Yeah, and
inhibitor. So it's not.
it's interesting because there's this theory. So you, as you quite rightly say, aromatase inhibitors will like basically, it's, I visualize it's like having a sponge and you're getting every scrap of water out of that sponge. The aromatase inhibitors are
Yeah.
getting every scrap of estrogen, and I've already said they block that aromatase, that conversion. So there is some school of thoughts, and I've heard lots of people mention it at a conference I've been to. If you have vaginal estrogen, you might introduce a tiny bit of estrogen, and you don't want that, and the aromatase might not work. And then you think, hang on a minute, you're talking about a really small dose of estrogen. And then I've already said women produce estrone, they produce different types of estrogen anyway. And there's no harm of even a small dose, well, there's no proven harm. But actually, so it doesn't make sense just because they're on an aromatase inhibitor. But then also, that's another reason for giving prasterone, because you're giving something that converts to testosterone. Because you could argue that, well, you're giving estrogen, but it's going to be blocked anyway. So is it going to work? Well, we do know that women do say they notice an improvement. But in my experience of giving prasterone to women who've had breast cancer, it's been absolutely transformational rather than just a little bit better for their localized symptoms. And these women, when I see them and they can't sit down for long periods, they can't wear underclothes, they're getting urinary symptoms, that can make a massive difference. You know, most of us have had UTIs and they're horrid. So, you know, and it makes more biological sense almost to give local testosterone. I know it's not available on all formularies, but certainly using localized hormones, whether they're the progesterone or different types of estrogen. Then people might have to use different types. Some people prefer the gel, some people prefer the vaginal tablet, some people prefer the silicone ring. Knowing there's a choice and you can use them alongside the non-hormonal preparations is also really
Mm,
important
mm,
to know.
mm. In everything you do when you speak to cancer patients and you help them manage their menopause, whether you prescribe a version, as we discussed, there are many of HRT or not, and you give them other non-hormonal medications, you do it because you're there in front of that patient. And I can really hear your passion, that you just really want that best to work out a good plan with that patient. Do you have thick skin, Louise? I want to ask you, because how do you feel when there are people around you and you've gone on to do great things, but obviously there are people, like we all know, that criticize some of your work or they call you almost a maverick in what you
Yeah, I
do? How does
think
that make you feel?
yeah, I don't have thick skin. You know, there are lots of times that I get very upset, get very tearful. I want to throw the towel in. And then I see a patient in my clinic and they say, you know, if it wasn't for you, I really wouldn't be here. And I think actually, and firstly, my children won't let me stop. But it is, I think also the other thing is, it's like my children, whenever they've been bullied at school, you work out who the bully is, and it's often someone who's quite insecure, who's had a difficult time, or you know something about their home circumstances, and you feel sorry for that bully, actually. And I think when people do say things on social media or whatever, these people don't know me as a clinician. They don't know me as a person. They don't come and sit in my clinic and read the notes and see what's happening. And I've invited people to come. Anyone can come and see what I do. So I'm not hiding anything. And so I think a lot of it is perceptions and misperceptions. And I think, you know, I could get deeply upset and it could affect me. Like, you know, when my children have been bullied at school, but you've got to think about what you're
Mm,
doing that is good and is right. And when things are based on uncertainty, that's fine to have uncertainty. And a lot of people don't have, I'm very fortunate, I have a massive clinical practice. So I'm not in my ivory tower writing guidelines because that's quite different. If you know, it's like if you do your amazing work, Danny, and you've never spoken to a lady who's had breast cancer or any type of cancer, it's very different. So, you know, I think also, like, I learn in life that you can't please everybody. I don't want to be a people pleaser. I didn't go into medicine to let everyone love me or be part of something. I'm quite a socially awkward person. I'm really quite academic, and it upsets me when people say, oh, they can only have vaginal hormones if they go and see an oncologist. And I think, well, why is my brain different to an oncologist's brain? Oncologists are very clever, but I'm clever too. And I'm not going to allow a woman to suffer while she's waiting for a referral to come through to an oncologist who should be seeing people with active breast cancer, not a lady who 20 years ago had breast cancer. So I
Yeah.
think there's still a bit of a patriarchal society when it comes to medicine. And, I think people, when they say, well, she's only a GP or she's a celebrity doctor, I think, hang on a minute, I've got a first-class pathology degree. I'm a member of the Royal College of Physicians. I'm a fellow of the Royal College of Surgeons. I'm a fellow of the Royal College of GPs. And I've read more academic papers than most people I know. But so I think we just have to is choosing your battles, I think, as well. I know that I know that we desperately need more research and evidence, and I don't think anyone could argue with that.
No, exactly. And I speak to so many doctors every single week as part of the organization or at events, and they prescribe estrogen to people with a history of breast cancer all the time at big university colleges, Imperial College, University College London Hospital, up to Scotland. It happens, but often it's more hush hush and you are outspoken about it. And I think that is also a difference. In our lifetime, in our generation of women, being here as a middle-aged woman, and so are you, do you feel you're sort of opening our picture and pushing the boundaries a little bit? Do you feel you're helping us all move along in your own way? How do you feel?
I think so. I think what I'm doing is hopefully allowing people to think about menopause in a different way, allowing people to think about choice in a different way, allowing people to think about health of women in a different way, because it's always been like women's health, gynae issues, and it's not, it's more than that. So I think allowing people to think more about their future health. I'm very interested in longevity and health span rather than lifespan. And that's something that I think we all need to be more interested in as we're all living longer. So I feel just helping people make choices is a really important thing, because the more information you have, the easier it is to make decisions. And also knowing, you say it's interesting. There are a lot of people that do similar to me, but they're very quiet in the UK. I know that they're very quiet indeed, but globally they're not. I've got I work with some great doctors in US and other countries, and I have a huge amount of support for what I do, and that by academics and by really, really good clinicians. And I think that people don't realize that I'm not really working on my own. I'm just a bit gobby, but I'm not a lone voice anymore, which I was 8 years ago more.
Yeah. Thank you, Louise, for your time. It's been amazing to talk to you.
Thanks, Danny.
Thank you for listening to this conversation. I hope you have found so many brilliant pieces of advice and nuggets in this conversation that might help you to take this conversation forward and into your own thought processes. An effective communication between the patient and the doctor is crucial to really talk about our own risks versus our own benefits. And of course, we've got to go out there and find someone who's happy to have those conversations with us. And I think the access to those conversations really is one of your biggest hurdles. And that is what many of you are telling me that is happening for you in your lives, wherever you are in the world. I hear from lots of patients in the UK, from Australia, New Zealand, America, Canada, people from all over the world, really, who are tuning into the podcast, who are telling me Danny, I just want to find a doctor. I want to talk about my own risks versus my own benefits of going on HRT. How do I find a person? And it's really, really hard because it's postcode lottery. It really depends where you live. Can you afford private healthcare? I don't believe anyone should, especially after a cancer diagnosis, should have to pay for private health care in helping them manage their menopausal symptoms. This is something that has in many cases been brought on by our cancer treatment. And I really, really want to do everything we can so that people get the help they need from their cancer teams. But I know this isn't always possible. And so I just hope these conversations help you a little bit more in trying to figure out what is right for you. And let's stop judging each other. There might be things that have been said in any of our podcast conversations that you wholeheartedly agree with and wholeheartedly disagree with, and that's okay. I don't think there is any area in life, in medicine, where everyone always agrees. And what's really important is that you find your way, that you take the next steps that works for you, that makes you feel empowered. And maybe that is by disengaging into any more conversations. Maybe that's it. Maybe you've had enough. Or maybe you're curious and you really want to find a healthcare professional that can help you talk about it and is happy to talk to you about it. And so whatever your next steps might be, I hope these conversations have been really helpful for you. As always, you can email us, you can reach out to us to admin@menopauseandcancer.org. We will get back to you if you have concerns. Maybe you're a doctor and you want to tell us what you're doing in your clinical practice, then we're all open ears. One thing for sure, it is our mission to have things out in the open a lot more, because we know so many patients are sitting at home feeling very isolated, not knowing where to go. And so by having all of these conversations with some brilliant experts, we really hope it helps you along your own way a little bit in making empowered patient decisions. Thank you today. In our next episode, we're going to bring more patients on to talk about using hormone replacement therapy for their particular types of breast cancer, different types of HRT as well. And so, I can't wait to have that conversation with them. And for now, I'm going to link lots of things into the show notes, so check out the resources there as well.